I'm so just thrilled to be here today, and there's so much to talk about in acne and rosacea, still two of the most common conditions that we treat in dermatology. So I'm going to talk about some facts and some myths and try to set things straight for what our common understanding of these two conditions are. And the first one is that a lot of people feel like just because they can buy generic tretinoin or prescribed generic tretinoin and it's easy, that's all that they really need in terms of topical retinoids. But the truth is, when we look at generic tretinoin, we understand this is not a stable molecule. In fact, it's inactivated by both light and benzoyl peroxide. So if a patient washes their face with benzoyl peroxide wash, applies a topical tretinoin generic, walks outside, that's a double hit, and they're inactivating their drug. In contrast, adapalene is stable in both light and with benzoyl peroxide. We also know that tretinoin cream is pretty irritating, and in that particular formulation, especially in the generic formulation, it has a much more untolerated profile than, for instance, other topicals, including adapalene. When we look at the clinical trials of topical tretinoin, we know we have a topical tretinoin lotion that's much better formulated and much better tolerated than any of the other formulations. So that's what's new, is a topical tretinoin 0.05% lotion. We have other new developments in topical retinoids, and those include tazarotene lotion. And if you think about tazarotene, you'd say, well, we already have two different concentrations. We have a 0.1 and a 0.05. I just use the 0.05 if I'm worried about tolerability. 0.05 is not FDA approved for acne. It did not meet its endpoints. Only the 0.1 is. Yet now we have a 0.05% lotion that has an enhanced vehicle that actually is FDA approved. It has the same efficacy as the 0.1, but a much better tolerability profile. And we also have a new kid on the block, trifarotene. Notice it's 0.005%, highly effective in binding to that RAR gamma receptor. It's been studied both in acne on the face, but also on the trunk. And a lot of people would think, why would we use a retinoid on the trunk? It doesn't seem like it would work there. But it actually was very efficacious and also well tolerated in both areas. So I just talked about the fact that we can't use tretinoin and benzoyl peroxide together because they will inactivate each other. But is that always true? Well, we now have a fixed combination that utilizes a microencapsulation of full-strength tretinoin, 0.1%, with 3% benzoyl peroxide. And these unmixables are actually able to be mixed because each of them is wrapped in a silica shell. And the amount of wrappings that you have actually determine how that drug is going to be released. So each one is microencapsulated, and the drug can very slowly be delivered to the skin. So what that does is it allows it to be stable in the fixed combination, yet it delivers a very controlled amount of both benzoyl peroxide and the tretinoin to the skin, which actually modulates the tolerability profile. So this was studied as a fixed combination in patients aged 9 and up, once a day for 3 months. And these patients had a lot of acne at baseline. They had between 80 and 100 papules, pustules, blackheads, and whiteheads. And what we found was that the patients who came into the trial really mirrored the type of acne patients that we generally see, the same type of patient population. And we see on average that the lesion count was really close to about 80 lesions overall. And what we found was that the efficacy profile, almost 40% of patients actually got to clear or almost clear with that 2-grade improvement. And for a once daily drug, one thing once a day for our patients, that really simplifies the profile and helps them be successful in their treatment regimen. Here's an example of a patient with pretty significant acne. We would not think about using a topical monotherapy, yet a really nice result without any systemic influences at all. When we look at the tolerability profile, because we have a very controlled relief of both actives, we actually have a very good tolerability profile over time. So is it a fact or is it fiction that we can reduce sebum topically? If you go online, you actually find a lot of different ways that you can reduce sebum. You gotta buy the right cleanser, you gotta buy the right moisturizer. Maybe we can use a retinoid. Don't they decrease sebum? They certainly dry out the skin. But the truth is we can't reduce sebum topically. We can decrease the inflammatory profile. We can decrease the inflammation. We can kill off the C. acnes, but we haven't been able to actually reduce the sebum. That's until now. And for any of you who are listening to Dr. Kursick, he very eloquently described how clascoterone actually targets the sebaceous gland androgen receptors. It competes with dihydrotestosterone, and in the area of the sebaceous gland, at least in vitro, we found that this topical medication can actually decrease sebum production. It can decrease pro-inflammatory cytokines and decrease the downstream inflammatory pathways. So this was studied in two sister studies, phase 3 clinical trials, as was mentioned, all the way down to age 9, although the indication is for 12 and up. And again, it's a monotherapy study, one medication twice a day in a nice cream formulation versus the vehicle, and we studied this for 12 months. And then we did do a long-term safety study, making sure that the drug was safe and efficacious over the course of a year. So what did we find? When we look at acne studies, we always look to see, does it work well on the papules and pustules, and does it work well on the comedones? And what we found was this drug actually hit its mark for all type of acne lesions, the papules, the pustules, the comedones, as well as the overall lesion count. In terms of local irritation, actually not much different from vehicle. And what's unique is when we talk about a topical acne medication, we're really worried about local irritation, and we didn't see that with this particular drug. In terms of the long-term safety study, no new safety indications or red flags. Now, how many of you would write benzoyl peroxide for a rosacea patient? If you told your patient, go on down to Target, pick up a benzoyl peroxide, use it on your moderate to severe rosacea, let's see how you do, chances are that patient will never come back to you, and you'll probably get a very mean review online. But utilizing that same technology of that silica shell wrap, we actually now have a 5% benzoyl peroxide that's been FDA approved and studied for moderate to severe rosacea. These were studies, adult patients 18 and up, using one drug once a day over the course of 12 weeks. And what we found was up to 50% of patients got to clear or almost clear with that 2-grade improvement. These efficacy results are quite high, again, just for a monotherapy. But what we also found was the skin tolerability profile was quite good. In fact, patients' tolerability was better after using the drug for 2 weeks than it was at baseline. And here's an example of a patient over the course of their rosacea journey. And you can see at week 2, no increase in erythema or scaling, but in fact a decrease in overall erythema and continued improvement over the course of 12 weeks. Here's another patient with skin of color, and we have to remember we see rosacea in all skin types. Again, a nice decrease by week 2. This patient is a treatment failure because they didn't get to clear or almost clear. Yet when you look at week 12 and compare it to baseline, a nice improvement. This patient is still happy. We also have a long-term study that found that up to 2/3 of patients actually got to almost clear over the course of the trial, and many of them actually got to completely clear skin. What about sarecycline? This is a drug that has a very potent anti-inflammatory properties, very narrow spectrum of activity, and it's FDA approved for acne, yet Leon and Jim Del Rosso were involved in a phase 4 study looking at this drug for the treatment of moderate to severe rosacea. And they compared it was blinded, compared to a vitamin pill over the course of 12 weeks. What they found was, you know what, even in this small study, sarecycline, with its anti-inflammatory profile, appears to work pretty well in rosacea, not just acne. So the final thought is, can we actually modify the course of the disease of rosacea? Can we act today and maybe influence how we're going to look down the line? Kind of an interesting thought. And we have some long-term studies with the alpha-adrenergic agonists looking at the reduction of background erythema over time. This study with oxymetazoline, which vasoconstricts those peripheral vessels, decreases the redness. But what's interesting is we found that in this study at day 1, we saw that we did get to clear or almost clear in their background erythema, or a 2-grade improvement, at hours 3 and hours 6, but nobody at baseline was clear or almost clear. Yet the longer we use the drug, the more we find that as the patients come in at the beginning of their day, they're having a reduction in their overall erythema. The end of a year, we found that almost 11% of patients really had minimal erythema even before they put the drug on, and the drug worked better and better and better over the course of time. So their baseline is moving. As opposed to being a very red face when they wake up in the morning, now they're waking up in the morning and some of them aren't even seeing a red face. When we look at the clinical photographs, especially in the second one, look at his baseline before he even puts on the drug at day 1, and then look at him at week 52. His background erythema is almost gone. Are we modifying the disease course? We have no idea at this point. We need further studies, but it's an interesting idea. So the bottom line is that our understanding of acne and rosacea continues to evolve, and our facts of today may become fictions of tomorrow. Thanks so much.